Now, in the previous section, we discussed about the pre-operative planning. Yes, we need to do all the x-rays and workup beforehand, but sometimes we need intraoperative radiographs as well. Why we need them? That is because to make a more sense, a 3D sense of what we are doing. Plus, sometimes we have to, sometimes a situation arises like a perioperative fracture or anything, for which we have to change our planning accordingly. Therefore, for that reason, we need intraoperative radiography. In this, we'll be going through the image guiding systems, which are usually utilized, robotics surgery, and briefly discussing the consequences of use of too much X-rays or fluoroscopy in the theater, that is the radiation exposure. As you know, spine surgery is a very complicated surgery. It not only involves you need x-rays from multiple planes. Actually, usually during a spine surgery, two fluoroscopes are used, one showing image in AP view and one showing the image in the lateral view at the same time. So the surgeon is very much sure that if he or she is actually putting the pedicle screws in, they are not going into the spine, or they are only going towards the pedicles or to the lateral masses. They are not entering into the spine, which may eventually damage the spinal cord. Similarly, not only the intraoperative imaging during the spine surgery, we also require neuromonitoring during the spine surgery, especially the case of scoliosis. When usually when the correction has been done for the scoliosis curve, we need neuromonitoring so that we do not overcorrect or correct to such extent that eventually leads to neuronal injury or spinal cord injury, leading to paralysis. So we need to monitor for fracture reduction, osteotomy alignments, as you know, because AP and lateral radiograph perioperatively will show us more of a 3D sense of the fracture, plus position of the implants, whether all the screws are in the normal position, whether they are going crossing the next cortex or not, or what is actually happening, and what is the length of the screw which is actually needed. And then position of the fixation devices, that if we have put up a nail, for example, if it's a dynamically or statically knocked nail, whether it's all intramedullary or not, and whether the screws are actually rightly in place so that it can keep the nail in intramedullary locked position or not. Fluoroscopy is actually required. It's actually easy to use. It's basically a C-arm, which is actually utilized. So it actually gives only uses an X-ray machine, which is giving us a per-operative live images of the X-rays when we are doing the surgery. The resolution is not as high as standard radiographs, but it actually is helpful because per-operatively all you need to see the implant, screws and plates and nails where it actually is going, and whether you have reduced the fracture or not. We may not be needing a very clear-cut view of the whole bone as well. Smaller low emission surgeon operated devices have actually now evolved. Why? Because sometimes we may have to use a lot of x-rays, and eventually it actually creates a lot of radiation exposure and hazards for the surgeon and the staff which is actually in the operating room. Therefore now low emission actually machines are coming up, which although do x-rays but actually emit very low amount of radiation. Intraoperative radiography, yes, if formal radiographs or CT scans have been employed as well, but not in all centers. Although post-operative and pre-operative CT scanogram is readily available almost all over the world. But we have to sometimes, X-rays is actually adequate. Sometimes we may be needing, for example, CT scan. For example, if a surgeon has done surgery for DDH and close reduction was done post-operatively, the patient is in spica. That is, the child would be in certain hip spica. Therefore, that plaster will prevent to surgeon to properly evaluate whether the head is reduced in the acetabulum cup or not. Therefore, then we need CT so that it can help us evaluate exactly, because plaster of Paris usually does actually kinds of overshadows sometimes the critical areas, and we are not able to evaluate the bone alignment properly. Other options are radiographic cassettes, which could be wrapped in sterile drapes and can be actually utilized to view perioperatively. Although nowadays usually orthopedic surgery rarely requires it except in few cases of pelvic trauma where angiography may be required, but usually In cardiology, this is very common practice. We're using an angiography first to actually view all the vasculature and then deciding whether they want to ligate or not. Other option is actually, if you see, this is probably this fluoroscope or spine surgery in view, in which is actually showing the x-ray at the same time in multiple planes, so that the surgeon has actually clear-cut idea whether he or she is going into the pedicles or lateral masses, or the screw is actually going into the spinal cord or not. As you know, the screws insertion into the vertebral pedicle is very important, and we need a 3D view of it, especially because otherwise, if the screw goes into the spinal cord, this can damage, and this could be disastrous for the patient. Positioning of the joint replacement components, you know it, that usually certain degrees of varus valgus alignment is required in knee. We need some degrees of 10 to 15 degrees of anteversion at the hip. So this 15 degrees of anteversion, this has to be determined by use of image guided systems. Other option is actually using of optical tracking method. Actually nowadays there is RGIGs available which actually connect these systems to the in a computer based program, which can actually help us accurately delineate the anatomy and exactly pinpoint the area where we need to put our jigs in. Like we use optical tracking, they use maybe using implanted markers, or they may be using intraoperative radiography with suitable software. These are multiple modes of method by which we can increase the accuracy of our surgery, therefore decrease chances of revision surgery, which may be eventually needed if its implant malpositioning is noted post-operatively. Other options nowadays is actually the robot assisted or robotically assisted surgery. Although it's rarely done, it's still emerging and evolving, but it's actually costly, so it's not done all over the world. There are a few highly specialized centers where it's actually been done, but it can be used in joint replacement. It improves accuracy and reproducibility, and interaction with robots could be via 3 ways. Basically, it's called as haptic feedback, in which we can use the touch. The surgeon is actually controlling the arm of the robot from a different way, and but the robot is actually performing the surgery. The other option is actually force constraint, in which a different force is actually utilized, and then computer programs are helped to so that the robot can perform. Even if the surgeon is using too much force, it will not actually exceed the force beyond a certain limit. The next is telemanipulation. That is actually the surgeon is not even in touch with the robot, but is actually controlling the robot through sitting at a different level or away from the robot. Therefore, in kind of a telemanipulation in which the robot is performing surgery, but instructions are actually passed from the surgeon for the robot to perform that kind of a surgery. Then again, with every positives, there are always negatives. There is always pros and cons of everything, and unfortunately, this staff, working doctors, nurses, the paramedics, they're always exposed to radiation, especially in case of an orthopedic surgeon, because we in orthopedic surgery, they frequently being utilized intraoperative radiography, especially the fluoroscopy is being done very commonly. Therefore, all the staff is actually exposed to increased amount of radiation. There is always the risk to patient, but the most risk is actually to members in OT. Recommended dose limit usually for the radiography is 1 millisievert per year. That is equivalent to 1000 chest x-rays. So you can well imagine there's very lot of debate now going on that instead of decreasing the exposure, what we can do is we can use the protection so that surgeons can perform the longer surgeries for a longer period of time, for a longer duration of the year. Fluoroscope images actually emit radiation. This could be pulsed exposure, there could be reduction of the total exposure which may be required, and for surgeon the risk is usually greater because he or she is actually exposed the most at most of the time. How we can prevent this radiation exposure is actually although it varies, continuous radiation is rarely utilized, but in some procedure you need a continuous radiation in which you need to see the image as you're drilling the bone into the bone. Therefore, that actually exposes surgeon to increased amount of radiation. But not all procedures require continuous radiation, so it actually varies with different procedures for different time. X-ray assistance may be required in some. Usually the protective measures include like we need to be protected, use protective measures so that there may be an influence of the cumulative exposure. For example, lead aprons are now coming in, especially the lead aprons actually shield the vital parts of the body such as chest, heart, lungs. Even there is a thyroid shielders as well now, in which they use a different color which can be utilized so that the thyroid is actually shielded, and these are especially required for the thyroid and those exposed testes and thyroid. These are their hyperactive glands and therefore their increased exposure of the radiation. Other option is actually thyroid shield decreases the dose by another 2.5 times, and usually that is very important. It should be worn in peroperatively. In this section, we have briefly gone through the peroperative radiography. As you know that it's actually for an orthopedic surgeon to reduce a stiff fracture and make it a stable fixation and make it a stable osteosynthesis, it needs a 3D view of the surgery. Therefore, to make itself more comfortable with the 3D of this fracture, usually requires peroperative radiography in form of fluoroscopy. But with every positive, it brings from more hazard as well, because the surgeons, especially the orthopedic surgeons, are at increased risk of exposure to radiotherapy, which can be prevented by use of lead aprons, especially using lead aprons along with the thyroid collar. Keep watching sqadia.com. Thank you very much.